All right. So this will be our last lecture if they don't ask me to add some more lectures. Yeah, because I saw that in the timetable there are some lectures I still don't have the lecturers. Yeah, but I don't dare to offer myself lah. I'm quite busy with the undergraduate. So okay, so I just Theophylline. Have you learned this TDM Theophylline in undergraduate?
uh, I think got touch a bit lah because we have this pharmacokinetic, but then they crumple everything like in one semester for one subject like that.
Mm, okay. So before we go into the calculation, just a few slides for our reminding. Yeah. So theophylline and aminophylline. Yeah. So theophylline is 1,3-dimethylxanthine. Yeah. So this is the molecule. Yeah, xanthine. And 1,3. So this position 1, 2, 3. So 1 and 3. Yeah. So 1 and 3 dimethylxanthine. Yeah. And molar mass is 180.1. Yeah, 0.2 lah. Yeah, so it's so gram per mole. And then wait, I think just need to and for aminophylline, actually aminophylline is theophylline um, ethylene diamine, yeah, ethylene diamine. So what happened is so aminophylline is there are two molecule of aminophylline and with ethylene. So this one's C 2C, yeah, ethylene, yeah, 2C, and there's a diamine, yeah, diamine, ethylene diamine. So and there are two molecule of theophylline. So what's the difference between this theophylline and aminophylline? So maybe I can I forgot to add here. Yeah. So theophylline is not soluble in water. Yeah, and aminophylline being a salt, yeah, it is soluble in water. So you will see um, injection. Yeah, there is no injection of theophylline. Injection is mostly aminophylline. Yeah, because we have to make aminophylline first so that it can be dissolved. So when it can, because in order to make injection, you have to dissolve first, right? You cannot have injection that cannot dissolve. Yeah. So all the injection will be aminophylline, not theophylline. Yeah. So theophylline ethylene diamine, and the molar mass is 420.4. So that is two molecule of theophylline, yeah, plus a ethylene diamine. Okay. So 1 mole of aminophylline equal to 2 moles of theophylline. Yeah. So so the S is here 0.8. The S, yeah, 0.8. So we have to times we have to divide by 0.8. So actually the aminophylline, yeah, is so if we want the if we use the aminophylline, so we have to times the S is 0.8 so that we can get the theophylline. Yeah. Yeah. So the clinical uses, due to its narrow therapeutic window, theophyllines role in asthma and COPD has been replaced by safer and more effective agents, yeah, such as um, beta-2 agonist, antimuscarinic, yeah. For current indications for patients who fail to respond to inhaled corticosteroids and long-acting beta agonists in chronic management of asthma and COPD. If you remember asthma management, you have got like a staircase, right? Yeah. So step up wise, step up and step down. Yeah. So as this is not theophylline is not the drug of choice. Yeah, it is actually a tertiary alternative. Yeah, in status asthmaticus. Yeah, so we know status means continuous, right? So if the patient is continuously having asthma attack, yeah, um, without stopping, yeah, so it's called status. Yeah, you have status epilepticus, right? Nah, so status asthmaticus. So which failed to respond to beta agonist and corticosteroid. So our first option will be beta 2 agonist plus minus antimuscarinic. Yeah. And second option will be magnesium sulfate infusion. Yeah. Okay. So the third only theophylline. Why actually theophylline is quite effective, but why we don't use it so much is because of the narrow therapeutics window. Yeah. Now, mechanism of action, various mechanism of actions have been proposed, such as phosphodiesterase inhibition, yeah, adenosine receptor antagonism, histone deacetylase activation, apoptosis of inflammatory cells, such as neutrophil and T cells, and increased interleukin secretion. As we know, interleukin is a lot of um, inflammatory mediators. Yeah, they are interleukin, but not all interleukin are bad. Yeah, but some interleukin are good only. Yeah, some are good, but a lot of interleukins are bad. So if you see this picture, yeah, the two most common mentioned mechanism, yeah, is the phosphodiesterase inhibition, yeah, PDE, phosphodiesterase, yeah, PDE. So it will block this PDE so that we will have more cyclic AMP, yeah. And cyclic AMP can cause bronchodilation. Okay. Now, theophylline also will attack here. Yeah. So antagonist adenosine receptor, because then it will inhibit the vasoconstriction. Yeah, because the adenosine receptor will cause vasoconstriction. Okay, yeah, so it will inhibit this one. So it will also inhibit acetylcholine. Yeah, this is also a muscarinic. No, sorry. Theophylline will attack here, but muscarinic antagonist, we already learned. Yeah, muscarinic antagonist, they will attack. Yeah, compete with acetylcholine. Yeah, so which also will cause dilation. Yeah, so like tiotropium, ipratropium, these are muscarinic antagonists. Okay, so at least we have two major mechanism of actions of theophylline, yeah, which is the PDE inhibitor and adenosine receptor inhibitor. Now the dosage, okay, modified release preparations, adults is from 200 to 500 milligram. BD, yeah, is a BD dose. Children 2 to 6 years, 60 to 120, yeah. 6 to 12, yeah, is half of the adult, okay. And loading dose by IV infusion over 20 to 30 minutes. 5 milligram per kg. So this is the standard dose, yeah, 5 milligram per kg theophylline or 6 milligram per kg, yeah, if we use aminophylline. Followed by IV infusion of maintenance dose. in general, in an addition of 0.5 milligram per kg, okay, will increase the concentration by 1. Yeah, but this is in general. Okay. Let me, this is there's a typo here. Okay. Rate of absorption from modified release preparations can vary between brands. Yeah, so if we are using modified release, so we have to be aware not to switch brands so easily. Yeah, unless if the specified brand cannot be found. Yeah, so you can switch, but must warn the patient. Okay. So typically for from 400 until 1000 every 4 hours. The relation between the plasma concentrations and its toxicity or therapeutic action, yeah, the adult therapeutic range for asthma COPD is 10 to 20 milligram per liter. Yeah. Now, in the UK, they also use micromole per liter. Yeah, so it's 55 to 110 micromole per liter. For neonatal apnea or bradycardia, um, it it is 6 to 12 milligram per liter. All right. So concentration dependent toxicity, yeah, from 10 to 15. Actually, 10 to 15 is still therapeutic range, right? But it may already exhibit some mild toxicity such as nausea, diarrhea, insomnia, nervousness, and headache. Yeah. And above 20 milligram per liter, it causes serious side effects such as persistent vomiting, GI bleeding, seizures, cardiac arrhythmias, and cardiorespiratory arrest. And more than 35 milligram per liter, sorry, more than 35 milligram per liter. So it will cause dangerous arrhythmia. Yeah, so if you look at this, yeah, so from the minimum side effects until dyspepsia, headache, yeah, restlessness, tremors, vomiting, agitation, tachypnea, flushing, and hypotension. Okay, until convulsion, shock, and arrhythmia. Okay, so our pharmacokinetic parameters, yes, optimum sampling time. Yeah, so normally we take the trough, okay, immediately before the next dose. Or if you want to take peak, yeah, peak must wait until finish absorption and finish distribution. Yeah. So the peak for modified release, yeah, because modified release you have to wait until all, yeah, being released. So it's around 4 to 8 hours post dose. Yeah. And rapid release, you can take 2 hours post dose. Time to peak. So if it goes up, and time to peak, 1 to 2 hours post dose, yeah, for rapid release. Okay. For modified release is 4 to 8. Time to peak, yeah. So route of elimination, yeah, hepatic metabolism. Okay, only less than 20% excreted renally. Yeah. Elimination half-life 3 to 9 hours. So this is a very big gap, yeah, from 3 to 9. Okay. Time to steady state 2 to 3 days. Okay. The target range is now the target therapeutic range is 10 to 20. Yeah. Or in the protein binding is less than 50, is around 50%. Yeah, the protein binding. So this is not so significant. Yeah. So those above 80 or 90, yeah, is more significant. Okay, so as mentioned, theophylline has a lot of various salt forms. Yeah, like it can be from aminophyllin anhydrous. Yeah, the salt form is 0.86. Aminophyllin hydrous. So hydrous means there is water, right? So the S is 0.79 and theophylline monohydrate is 0.91. Yeah, monohydrate. Okay, bioavailability. So if we take IV or oral liquids is 100. The oral tablet is 90 to 100. Yeah, and then you have the suppository from cocoa butter is slow and erratic. Suppositoria is a bit more. Yeah, rectal solution also. So theophylline is not really much affected by bioavailability except for the modified release. Yeah. Okay. The metabolism 85 to 95% metabolized in the liver by demethylation by CYP, yeah, 1A2 and hydroxylation by CYP2A1. Aminophylline metabolite, yeah, is 3-methylxanthine, okay, and which has no pharmacological effect. And in neonates, the N-demethylation pathway is absent. So 50% of theophylline is excreted unchanged in the urine. So in normal adult, it must be only 20. Yeah, but in the this patient will have around 30. Uh, uh, so 7 to this is interesting thing in neonates. Yeah, 7 to 10% will be converted to caffeine. Yeah, so there is a similarity between caffeine and theophylline because they are also xanthine. Okay, and caffeine has a longer half life, about 100 hours. Now the clearance, yeah, can be increased by smoking, chronic alcoholism, chronic, yeah, alcoholism, hyperthyroidism, yeah, because of the increase in metabolism, yeah, cystic fibrosis as well, low carbohydrate and high protein diet, yeah, hepatic enzyme inducers such as phenytoin, carbamazepine, and rifampicin. These three are then there are also etc etc. Yeah, but these three are well known as enzyme inducers. Now the clearance also will be reduced by heart failure and acute pulmonary edema. Okay, cirrhosis, viral hepatitis, viral infections, and hypothyroidism. Just now the hyperthyroid can increase, yeah, hypothyroidism can reduce, and sepsis with multi-organ failure, yeah, and hepatic enzyme inhibitors such as erythromycin, cimetidine, vancomycin, ciprofloxacin. Yeah. Now, what I want to say here. If you see the clearance, yeah, clearance in premature neonates, yeah, the clearance is smaller. The smaller the clearance means the slower it will be cleared. Okay, But the initiated early children, yeah, can actually. So why these neonates? Yeah, neonates is smaller the clearance. Why smaller? Because they don't have the enzyme that metabolize, yeah, the theophylline. Okay, lack of the enzyme. Yeah, so the metabolism is less. Yeah, so the theophylline will be um, higher. Yeah, the clearance. But to the certain age, like 6 months, 9 months, yeah, because they are actually growing up very very fast. So, and also the children until 15 years old, yeah, so they have a much higher clearance than the
Betul?
adult, yeah, than adult. If you see adult, 0.04, yeah, 0.04. But a little bit only lah, yeah. And from adult also, there's a difference between non-smoking and smoking, yeah. Smoking can increase. Okay, so if you see elderly non-smoker, it is lower because of the renal function, liver function. Yeah, but the smoking one will be higher. Yeah, the asthmatic. Now, so smoking. This is another from another book. Yeah, so if you see the hepatic disease, they will decrease. Yeah, the clearance. Okay, and if we have got smoking, yeah, it increase the clearance. Okay. COPD itself, yeah, decrease the clearance. COPD, yeah, like just like hepatic. All right. Do you know what is cor pulmonale? Cor pulmonale.
Don't know.
You don't know. Cor is for heart, yeah. Pulmonale. So there's a like right. Actually, cor pulmonale is also another term for right-sided heart failure. No, right-sided heart failure. Yeah, and right-sided heart failure normally is caused by increase in pulmonary hypertension. Yeah, so the blood pressure in the pulmonary artery and pulmonary vein, yeah, is higher. So it causes the right-sided heart failure. Okay, so it will decrease and decrease. Okay, drugs also, if you see that cimetidine, yeah, it increase the clearance adjustment. What is this? Cimetidine is inhibitor, right? When you inhibit, so how the clearance will be smaller, right? Yeah, so meaning that this is times, yeah, so it is smaller by half, okay, or 0.7, yeah. So those inducer like phenytoin, phenobarbital, yeah, so it is a bit higher, you see, higher, yeah. Erythromycin is inhibitor, propranolol is inhibitor, okay, verapamil not so, yeah, so a bit lower also, but rifampicin will be higher. Okay, sampling time and monitoring, yeah, for neonates, infants, and children after the loading dose. So why we take sample after the loading dose, yeah, if necessary, but we don't normally do, okay, to get the VD, because from there you can get the VD, yeah. Neonates 2 hours post loading dose, infants and children 30 minutes post loading dose. After the initiation of maintenance dose, so after one dose, yeah, initiation, 8 to 12 hours when necessary. Yeah, but most of the time not necessary. If clinical stable, then 72 hours after initial dosing. Okay, so around 3 days. Yeah, if stable, so after that 72 hours, if stable, then we only do every 1 to 6 months. Yeah, it depends on the person. Yeah, and stat sampling, we do stat sampling if suspect toxicity. Now for adults and geriatrics, after loading dose, 30 minutes. Yeah, so just like the infants and children, after the first maintenance dose, 12 to 24 hour if necessary. If clinically stable, is the same. Yeah, after 72 hours, then repeat 4 to 7 days later. For stable patients, every 1 to 6 months. Stat sampling if suspect toxicity. Okay. Now this one we will. I don't have to read all. You can read by yourself. Yeah. So if let's say the serum concentration is below 9.9, so it means that below the therapeutic range. Yeah. So maybe you have to assess clinical outcome symptoms. If not improve, consider 25% daily dose increment. Mm. We assess serum concentration after 3 days of new dosing. Yeah, if we do change, you have to investigate and etc. etc. You see, there is a difference between oral and IV. Yeah, and yeah, so you have if you have a higher one because this one is actually subtherapeutic. All right, so these are you can read by yourself. And then later when we have our case study, we can refer to this. So I think our case study is here. Assess clinical symptoms. If symptoms control, continue current dose. If symptoms not well controlled, consider alternate or additional therapy. Yeah. So if IV assess clinical symptoms, if symptoms control, no adjustment requirement. If symptoms not well controlled, consider alternate or additional therapy if possible. Now, same thing, yeah, but with a higher concentration. Okay, we go to our case, yeah. So Mahmoud, a 62-year-old, 65 kg man with 30-year history of mild COPD, has been satisfactorily controlled with salmeterol, ipratropium, and inhaled budesonide. However, over the past 2 months, Mahmoud has experienced increased difficulty in breathing. His physician wishes to admit him to the hospital and initiate IV aminophylline. So calculate the appropriate loading dose of aminophylline for Mahmoud that will result in theophylline concentration of 14 milligram per liter. For aminophylline, uh, S is 0.8, yeah, and the population VD 0.5 liter per kg. Okay, aminophylline is available as solution as this, yeah, 25 milligram per ml in a 10 ml vial. So everything will be 250. Yeah. Let me charge my computer. Okay, so let us see how do we calculate this. So we have got body weight 65 kg. Now we don't have the height, so we can't get the ideal body weight. Yeah. If the body weight is more than 50% higher than the ideal body weight, then use ideal body weight. Otherwise, just use the actual body weight to calculate the VD and clearance. Yeah. So we know from the population data the VD is 0.5 liter per kg, yeah, and his weight is 65, so we calculate, we get 32.5 liter, yeah, and the CP desired is 14. So we just pop in this easy IV bolus formula, yeah. So S times F times dose divide by VD. Okay. Or previously, this is what we normally yeah, um, use. Okay. This is the IV bolus. And then we get the dose CP times VD divide by S times F. So we just put CV 14, VD 32.15, and then the F 0.8, then we get 568.75 milligram. Yeah. So as we know that we have got a vial of 225 milligram per ml, so in total 250. Then so we can if we divide by 500, so we can get 2 times 10 ml vial. Okay, so we get it from where? So
So
yeah, so if we get 500, actually the concentration will be lower. Yeah, if you want, you can calculate what is the concentration like. Yeah, are we happy with that concentration? Okay, so in some people will say, why not we just use 575, for example? Yeah, because 25 milligram per ml, 575 we can get, yeah, 500 ml from the two vials plus 75 ml. Yeah, but 75, sorry, plus 75 milligram. Okay, but because population data like VD and all this, they are not the patient on data, so it is just an estimation. Yeah, so you can either use 575 or whatever, but clinically more practical is 500, because then 500 you can use two vials only. Yeah, uh, to be given over 30 minutes. And please mind, okay, mindful that theophylline cannot be injected, yeah, less than 20 minutes. Okay, so it cannot be given so fast, because when I work in hospital, yeah, we had a patient actually died, yeah, when the nurse gave theophylline, yeah, aminophyllin fast. So the patient developed the cardiac arrhythmia and died. Yeah, and at that time I was asked to be, like, investigator of why the patient is, died. So we found out that the nurse actually has given the aminophyllin too fast. Then the hospital doctors asked me to give um, training to all nurses in the hospital, yeah, about giving of IV drug. Okay, so I went to from ward to ward, from ICU to NICU, etc., to give the training. So those days, when you work hospital. Okay, so this one is very easy. We calculate using the IV bolus model, yeah. But to be strict, right? Because actually this aminophyllin is given by IV short infusion. Yeah. So why not we calculate using the IV short infusion, just to compare the result. Okay. So because if we give through short infusion, actually the CP will be a bit lower. Yeah. If we use the same amount of um, drug, yeah, the CP will be a bit lower. Okay, let us prove it. Yeah, so the clearance, because on the way when we have infusion, there will be something, some drug will be cleared. Yeah, so for this we have to use this formula. Yeah, S time F time IR. Yeah, IR stands for infusion rate, divide by clearance. Yeah, and then times 1 minus E power by minus kt. Yeah, k is the constant, and t is infusion time. Okay, here is 0.5. So then we want to find the IR. Yeah, so the IR, the infusion rate. Yeah, so we have CP, etc., etc. Yeah, then we get, I hope my calculation is correct. So the clearance divided by VD 8.8 0.08 yeah per hour. Then we put into here, okay,
我们都
and then we get this IR 928.3 yeah if we divide 464 milligram. So we infuse 464.16 milligram in 30 minutes. The practical dose is to give 500 milligram. Yeah, but let me try to recalculate again because maybe it is a bit. I will just to check whether it is not wrong. Yeah? You also can help me to recalculate this. Um, the K is correct, not 2.6 divided by 32.5. 0.08 correct, yeah? So let's calculate this one, this part. This part. E E 14, right? 14 recipe. 14 times 2.6 divide by 0.8 times 0.08 times 0.5 is what? 0.
0.04.
0.04, yeah? Yeah, correct. Oh, this one wrong, yeah? That's why I was hesitating about this one. Let us. I think this one is wrong because supposed to be higher. Yeah, is in infusion. My calculation is 1,160.40 milligram per hour. So if in 30 minutes, so we just divide by 2. 5, 8. So this is the correct one, yeah? 5, 580.20. Okay, so we can practical dose we can give 500. You see a bit higher here is a bit higher. Yeah, you need a bit higher dose for IV short infusion because when short infusion on the way of that 30 minutes, yeah, it will already being eliminated a little bit. Yeah, so by right this one 568 and 580, yeah, so it is only if you take 580 lah, this one 570, yeah, so it is like only 10 to 12 milligram different, yeah, isn't it?
Yeah.
Yeah. So a little bit. So that's why in clinical kinetics we don't use this one because this is much more tedious. Yeah. So we just use this IV bolus. Understand or not? Yeah. Because it's easier. Okay. Now, the loading dose is to be administered over a 30 minutes interval. An aminophylline maintenance infusion is to be started immediately on completion of the loading dose. Suggest an aminophylline infusion rate for Mahmoud that will achieve a plasma theophylline of 12. So now we want a maintenance of 12. Yeah, the population clearance in non-smoking adult is 0.04 liter per kg. So we just times the body weight, we get 2.6. Yeah, and then we use this formula CPSS equal to S times F times IR infusion rate divided by clearance. Yeah, so CPSS, so we put it, just convert this one IR that we want. So it is the CPSS times clearance divided by S times F. Yeah, so we put in and then the clearance and all this, then we get 39, yeah, milligram per hour. Yeah, aminophylline, this one aminophylline, yeah, or 1.1, because the aminophylline is 225 milligram per minute, right? 25 milligram per minute, yeah. No, is it no 25? This one what our this one? 25 milligram per ml, yeah, per ml. So we got 39 milligram, right? Divide by 25, so 1.56 ml, yeah, or we can take 1.5 ml as well, okay, per liter per hour. So we just put this into the infusion pump, yeah, then it will pump out. Yeah, until here, okay.
Yeah, okay.
Yeah, so next, when should the plasma be taken for TDM? So in order to adjust the dose, etc., it is best to be taken at steady state, yeah, which is 3 to 5 times half life, yeah. And then we have to calculate the K, yeah. So K is CL clearance divided by VD, so we get 0.08 per hour, and the T half is 0.693 divided by K, so we have 8.7 hours, yeah. And time to achieve steady state 3 to 5 half life, so 26.1 to 43, so around this time, yeah. But to be practical, we can say that we can take the plasma 48 hours after the initial maintenance dose, so it means 2 days lah, yeah, after the initial maintenance dose. Okay, so now Mahmoud steady state theophylline serum concentration is 11.6 milligram per ml. So we wanted to achieve 10 to 12, right? And we wanted to achieve 12 actually just now, right? But we have only 11.6, yeah. So the patient is not breathless now, and is his saturation, oxygen saturation is 95, yeah. What would be your recommendation? So I will answer is, since the patient is responding well and his clinical condition has improved, we may maintain the current dose. Yeah, although the concentration is in the lower side, because 10 to 20. So this patient already have 11. Yeah, 11.6. Yeah, so a little bit only, not 15 or what. Yeah, but anyhow we wanted to achieve 12, right? So 11.6 should be okay lah, right? We are not treating, because we are not treating the number but the patient. Yeah, we are not worried about the number, we see the patient. If the patient responding well, then by all means continue the same dose. Yeah, furthermore, theophylline follows first order kinetic on the, so theophylline is pretty like the phenytoin. Yeah, so it follows first order kinetic on lower concentration, but on higher concentration, it tends to follow non-linear kinetic. Yeah. So we never know that the patient is already under the non-linear kinetic, because if the patient is under non-linear kinetic, so when we add a little bit, yeah, of those, it can spurt up, it can increase, yeah, the concentration quite high, yeah, not proportionate. Yeah. All right, so let's see this second. So actually I wanted to that we do together, yeah, the second one. Okay, can we do together? Sandy, an 18-year-old patient admitted to the E&E with difficulty in breathing. He has been prescribed theophylline for resistant asthma on an outpatient basis, but admits his compliance to this medication regimen is poor. A stat theophylline level is reported as 3.9, which is very low. Yeah, and Sandy's body weight is 47. Calculate an appropriate aminophylline loading dose to give Sandy a serum level of 14. The population VD is 0.5. Yeah, so we know the population 0.5. So the VD will be times the kg. Yeah, times the kg. Can you help me? What is the liter? How many liter?
23.5.
23. Yeah, 23.5. Because 24 is 48, right? Okay, liter. So now what we do, we need a loading dose. So the loading dose just now is equal to the CP, right? CP. So now we have the CP desired, yeah, desired one. So the CP desired minus CP, which is now measured, yeah, CP measured, times what? Times VD, right? Divide by S times F. Okay. So the CP, so can you calculate this one? 14 minus 3.9 times VD is 23.5, divide by 1 times 0.8. So equal to, so this one 10, right? 9.9, yeah.
10.1.
9.1, okay. 9.1 times
10.1.
10.
10.1.
Okay, sorry, 10.1. Yeah, because 14 minus 4 is 10. Yeah, 10.1 times 23.5 divide by 0.8. How much?
29.
Huh?
296.68.
29,
296.68.
296.68. Yeah, milligram like that. So we want to take 300. Can take 300, yeah? Okay, take 300 milligram. So if 300 milligram means we need to, actually, if we don't consider any economical reason, yeah, we can just take 300. But if we consider economical, then we take 250, correct or not?
Yeah.
Because there's one vial is 250, yeah. But never mind, if theoretical, then we take 300 lah, yeah. So this one, calculate an aminophylline maintenance dose that will maintain Sandy's serum concentration at 12. So it's the same. The population clearance is 12. Sorry, it's wrong. 0.04 liter per kg per hour. Okay, let's do it together. It's the same, right? This one. So we need a clearance first. The clearance 0.04 times 47 equal to
1.88.
1.88 liter per hour. Okay. So our dose, so the formula will be CPSS equal to IR, right? S kali F, S times F times IR divide by clearance. Yeah. So we want the IR. So it is the CPSS times clearance divide by S times F. So can we do this one? CPSS is 12 times clearance just now 1.88 divide by 0.8 times 1. What did we get?
28.2.
28.2 milligram per hour. Yeah, because this is an infusion, right? So if we want to convert to um, milliliter, then 28.2 divided by 25. What is that? 1 point something.
1.128.
1.128. Yeah. So probably we take 1.1 lah. 1.1 ml per hour. Okay. So a little very small, yeah. 1.1 ml per hour. So can you imagine 1.1 ml so little, right? Per hour. Because 25 milligram per hour.
Yeah.
Yeah, 25 milligram per ml. So we need to use the infusion pump. Yeah, the infusion pump will will do it for us. If you ask the nurse, cannot now 1.1 per ml per hour, cannot, yeah. So you have to use the infusion pump. Okay. So the last slide that we have, Sandy has been stabilized on his 29 milligram. So we calculated 28, right? Okay. 29 milligram per hour aminophylline regimen, and his steady state serum is now 13.2. Yeah, because we take a bit higher one, you see. Calculate a dose of sustained release theophylline for Sandy to maintain a theophylline serum concentration at 12. Yeah, and we know that theophylline comes under 100, 200, and 300 to be taken BD. So we calculate back for 12. Yeah, so we get the dose for 12 now. So we know the clearance just now. Clearance, what is the clearance again?
1.88.
1.88 liter. 1.88 liter per hour. So we use do you know that there's also like this, yeah, but it is S time F time dose. Yeah, just now kan we use IR. Yeah, IR is actually dose divided by tau. Yeah, so divide by S clearance times tau. Tau, okay. So we have now dose. Oh, we find the new dose first lah. Okay, because now this dose 29, you get 13.2, yeah. So new dose equal to desired CPSS divided by measured one CPSS times old dose. This one is when we use the linear kinetics, yeah. So the new dose will be okay. So I have to you can use this, but then I just want to show you that actually the clearance of this patient, this clearance is population clearance, yeah. So now since we already have the CPSS, so we can calculate the clearance of the patient. Okay, now let's get it, clearance of the patient, yeah. So we don't use the clearance from the population now. Okay, the clearance of the patients is what? Clearance is S times F times dose, yeah. Or if you want to use IR, you can use IR. Just
Night.
enggak mau, kita lagi ngajar.
Mau cium gitu.
Oh, lagi ngajar.
Cium dia.
Lagi ngajar.
Ya udah aku begini. Oke. Goodnight, I love you.
Ya, oke, oke. Bye.
I love you.
Ya. IR, yeah. So we go back to that formula. So our clearance will be S times F times IR divided by CPSS. 0.8 times 1 times IR 29, yeah, divide by the CPSS 30.2. So can you help me?
1.75.
1.75 liter per hour, yeah. So you see this is the patient's own clearance, which is lower than population clearance, yeah. Okay, so a bit lower. So now we want a new dose, new dose. Okay, the new CPSS, yeah, equal to S times F times new dose, because now we are using the oral, yeah, so no more IR because it's oral. Okay, so equal to clearance times tau times tau equal to clearance clearance new dose equal to PSS times clearance times tau and tau divided by S times F. Okay, so what with the CPS we want 12, yeah, times clearance 1.75 times tau. The tau is What is the town? Do you
12
know?
hours.
12 hours. Yeah. Divide by 0.8. Do we have to put 0.8 if we use theophylline? We don't need anymore to put 0.8.
No.
Do we need to put 0.8? No, right? Because it's theophylline. Yeah. So this one. Okay. So can you help me?
Two five two.
252
252.
milligram. Yeah, BD. So O equal to 250. Can we put 250?
Yeah.
Milligram BD. But if we say we don't have the 250, we have 100, we have 200, we have 300. So what we do? So I put a note first here that because for extended release tablet, because the extended release tablet is theophylline, not aminophylline. So the S is 1. Okay. Okay, so what we do with this 250 milligram BD, since we don't have 250 milligram, can we get can we use 200? But if we use 200, then become 400 only, right? Per day. Yeah, we need 500 per day. So and then the extended release cannot be half. So what we do, we can do 200 200 in the morning and 300 in the evening.
I was
Right?
thinking like that also.
Yeah. So for practical dose, we can supply the patient with 300 milligram tablets in the morning and 200 milligram tablet in the evening. Or we can supply the patient. The patient can take you can take. Okay. Asthma is more at night or in the morning?
Night.
More at night, yeah, at night, early morning. So we change to in the morning 200, at night 300. Is it okay? Yeah. So in the evening 300, in the morning 200. Okay, make sense or not? Yeah, I think this is the last slide. We have done our 2 cases as well. Do you have any question?
No.
Allah?
No, it's okay.
Yeah. So kinetics are not, it's not difficult, yeah. But it's just that these are quite simple calculations. But when you go into the vancomycin and gentamicin, it can be more complicated. Okay, if not, I stop recording.